Welcome to section 11 of the... When you think of the nerves of the lower limb, it's good to get an idea of the compartments that they service. So the femoral nerve will be servicing the anterior compartment and a major hip flexor and extender of the knee. The obturator will be an adductor compartment, which will adduct the hip joint. Then we have the superior gluteal nerve, which will do tensor fascia lata, glute medius and min, all abduct the leg and rotate it in. The inferior gluteal nerve will supply gluteus maximus as a forced extensor of the hip joint. And then the tibial in the thigh will supply the posterior compartment of the thigh, and it will extend the hip and flex the knee. It also has a component that's supplied by the adductor magnus, which it's going to supply, and that's the hamstrings component of adductor magnus, which attaches onto the adductor tubercle. In the leg, the tibial nerve will supply all the plantar flexors and inverters of the posterior compartment, both deep and superficial, and then it will cross into the foot and become the medial plantar and lateral plantar to supply the plantar foot. The medial plantar will do 3½ toes of sensation and 4 muscles known as the LAF muscles, and the lateral plantar will do 1½ toes of sensation and the rest of the foot muscles. And the 1½ toes for the lateral plantar, of course, will be the lateral toes, and the 3½ toes for the medial plantar will be the medial toes. The common fibular will cross over at the head of the fibula and divide into a superficial fibular and a deep fibular. The superficial fibular will supply the everters of the foot and the arch support that crosses under as the long fibular. And then we have the deep fibular nerve, which will supply the dorsiflexors in the anterior compartment of the leg, which are the true extensors. Let's look at a question. A 21-year-old steel worker has arrived to the ER after falling in a seated position onto some rebar at a work site. His co-workers immediately helped him up and called the ambulance. Upon arrival of the EMS, the steel worker tried to rise and walk to the ambulance, but immediately reported having difficulty getting up from his seated position. Which nerve was affected by the injury? For this question, we're looking for the inferior gluteal nerve as the correct answer. This nerve supplies gluteus maximus, which we'd mentioned earlier is the power extensor of the hip joint, so it assists you in getting up from a seated position or also going upstairs, which are going to be red flags for tagging that muscle and that nerve. The superior gluteal is going to be gluteus medius and minimus, as well as tensor fascia lata. The tibial nerve will do posterior compartment of the thigh and go on down into the posterior leg and foot. Obturator is medial compartment, and the common fibular is going to be supplying both lateral and anterior compartments before it has divided. Now let's look at the lumbar plexus. If you're familiar with this area, move quickly through it. If not, then review this as the major components of the lumbar plexus from subcostal through L4, and the lumbosacral trunk, which will be the remnants of L4 and all of L5 as it drops into the sacral plexus. This nerve goes right over top of the sacral ala and can oftentimes be injured in pelvic fractures where the sacrum is a component of that. As we look at the nerves that cross in the posterior abdominal wall, the subcostal nerve, the iliohypogastric and ilioinguinal L1 branches will cross over quadratus lumborum. They will exit into the abdominal wall above the ASIS. Nerves like the lateral femoral cutaneous nerve and the genital femoral nerve will cross under the inguinal ligament, along with the femoral nerve, to get into the anterior and lateral thigh. You really need to know the femoral nerve being on the lateral side of the psoas muscle and the obturator nerve being on the medial side of the psoas muscle, the femoral nerve staying in the false pelvis and the obturator staying into the true pelvis, because these can be affected in an abscess of the psoas muscle. So you can have sensory losses with the genital femoral, or you can have motor and sensory components if you're affecting the medial side with the obturator or the lateral side with the femoral. As far as sacral plexus, the L4, L5 lumbosacral trunk will then join with the S1 through S4 components, and they'll make up things like the sciatic nerve with all 5 of those, L4, 5, S1, 2, and 3 involved, and that will divide into common fibular and tibial. We have our gluteals and our nerve to piriformis, and the one that we really want to pick out here would be the pudendal, S2, 3, and 4, which is a somatic nerve that will be involved in the perineum as we get in towards pelvis. If we look at these as far as their nerve roots, you can see all of these branches and their nerve roots. I would spend some time knowing most of these actually for the test, especially those that are relevant to reflexes. So you should have a very solid control over the fact that the chord level being tested in a patellar reflex is going to be predominantly L3 and L4, which is the knee-jerk reflex. And for the L4 and L5, it's going to be tibialis anterior for the ankle reflex. And then finally the calcaneal reflex, which is going to be S1 and S2 for the plantar flexion ankle reflex. Here we've looked at the dermatomes. We've talked about them already. You will need to have an idea of how these distribute. I have a little poem that I use where it helps me to remember where they distribute. The first thing is that L1 is where you have your fun because it heads towards the genitalia and the groin. L2 is a hand width below because it's one spiraling hand width inside of that area. L3 is inside the knee. It heads to the medial aspect of the knee. L4 is where you hit the floor. It goes right across the kneecap itself. L5 is just out wide down the lateral side of the leg and onto the dorsum of the foot. S1 is a strip towards the bum, so it's a strip that goes up and over top of the gluteals. S2 is a strip that runs closer to, and then you start getting into the target zone around the anus, which would be 3, 4, 5. When you're thinking about the named nerves for the cutaneous branches, the medial thigh is going to be supplied by obturator. The saphenous is going to be a branch of the femoral that will run with the great saphenous vein below the knee only, and that will supply all of the medial leg down to the medial malleolus. And then you're going to have the lateral femoral cutaneous, which will be coming from the lumbar plexus underneath the ASIS into the lateral thigh. And then you're going to have anterior femoral cutaneous, which are branches off of the femoral, which will spray out as it comes under the inguinal ligament. And genital femoral will feed a femoral portion to the femoral triangle and a genital portion towards the genitalia. Let's talk about some nerve problems of the back and lower limb, because these are going to be clinically more important for your studying of the USMLE. So what about compressions of the spinal roots? We'd oftentimes discuss the fact that compressions of spinal roots will create back problems or even limb problems that are actually back problems in disguise because they'll send shooting pain down through the limb. And L4, L5 is common, and those two being compressed will give you shooting below the knee, which would give you sciatica. If you have an injury to the sciatic nerve, one of the common causes of that is after hip replacement, and the common fibular division is more vulnerable than the tibial division during the replacement. This is going to lead to flaccid paralysis of the hamstrings and paralysis of all the muscles below the knee because of the tibial division going to the posterior leg. To avoid the damage to the sciatic nerve when you're doing an intramuscular injection, make sure you stay to the upper outer quadrant of the buttocks, and be suspicious if there's a scenario that reads in any of the questions to have an injury anywhere in the other 3 quadrants, the medial half and the inferior lateral half. Other causes of damage to the sciatic nerve are going to be trauma, hip dislocations, especially posterior dislocations, which happen in high-impact traumas as far as motor vehicle accidents, and also pelvic disease. So what about injuries to the femoral nerve? The femoral nerve is superficial in the groin and oftentimes is injured through iatrogenic injuries, so physician-induced. The most common of which is a traction injury, which happens during hip replacements or during laparoscopic repair of inguinal hernias, where there can be too much traction put onto that nerve during the repair. It can be damaged during attempted cannulations of the femoral artery or the femoral vein while they're in the femoral triangle. Lateral cutaneous nerve of the thigh is really not too big of a worry because it's simply cutaneous, but it may have a neuralgia parasitica, which is going to be caused from tight pants, or from obesity and pregnancy where people have not replaced their pants for those specific situations. The obturator nerve is rarely damaged, but it can be impinged upon during pregnancy, or it can be impinged upon as a result of malignant disease in the pelvis. The superior gluteal nerve is going to be one of significance because it supplies the gluteus medius and gluteus minimus, which support the pelvis during gait. And this is damaged and causes the Trendelenburg gait, where it will be a lurching gait because the pelvis can't be supported by the contralateral gluteus medius and minimus. This is going to be oftentimes injured during hip replacement as well. The nerve itself lies about 5 centimeters proximal to the tip of the greater trochanter and approaches the hip, so you should not extend your cuts there more than 5 centimeters from the tip of the greater trochanter, otherwise it can be damaged during surgical repair. So keep your eyes peeled for that one in a surgical approach question that may be on the USMLE. We'll talk more about that injury in a little bit. Moving on, though, we have the common fibular nerve. This one is oftentimes damaged either at the hip as part of the sciatic, or the common fibular nerve is highly vulnerable to damage at the level of the fibular neck, where it can be hit and destroyed either through car accident and resulting in a foot drop. And you'll also have loss of sensation over the anterolateral leg and the dorsum of the foot. Of particular interest as far as dermatomes is the deep fibular nerve as it distributes to the first web space between digits 1 and 2 in the foot. So oftentimes this injury is called a car bumper injury because this is where pedestrians will oftentimes be hit by a car bumper as they're crossing the street, and this will result in a foot drop. Saphenous nerve injuries. It's a cutaneous nerve that's running with the great saphenous vein. It can be damaged at the medial malleolus after varicose vein surgeries or a cut down for fluid injection at the great saphenous, or during harvesting, and also during ACL repair surgery. It can be provided or damaged during an anesthetic nerve block, and these nerve blocks are oftentimes utilized to help substitute general anesthesia during surgery. So you may do a femoral nerve block or a sciatic nerve block or ankle blocks and lateral cutaneous nerve of the thigh blocks. And it's the understanding that you have of the peripheral anatomy that's going to allow the anesthetist to localize the best place as far as that local injection. And then you want to predict the level and the extent of the anesthesia provided by understanding the distribution of these peripheral cutaneous nerves. Let's go back to the idea of a lurching gait with this gluteus medius, also known as a waddling gait, and you can see that the pendulum, which represents the body's center of gravity, has now moved outside into the lateral edge. The problem with this is that the pelvic stability is compromised because the stance gluteus medius and minimus do not have the power to sustain the pelvic horizontal plane when the nerve is injured. That's going to essentially have an increase in the length of the limb, which cannot be cleared through a swing phase of a stance and a gait, and therefore they're going to throw their body to the side or swing their lower limb out on the unaffected side. Now, when you look at the gluteus maximus, or the extensor lurch, you can see how the gluteus maximus being paralyzed through the loss of the inferior gluteal nerve will throw the body weight behind you, and the hips will protrude forward, the shoulders will fall back, and you will lead with the groin in your gait because there's no power of extension at the hip. These people will, as we said earlier, have difficulty raising up from a chair, running, or going upstairs. This slide will show us a little bit more about the Trendelenburg gait because it's very important that you understand this. It's tested fairly commonly. The waddling gait is a result of bilateral or unilateral superior gluteal nerve denervation. And the stance leg essentially cannot support the swing leg to maintain a flat pelvic plane. Therefore, the swing side drops, and that ends up having to swing the hip out or throw the body to the side in order to clear the swing leg through the ground. Otherwise, you'll trip. So, let's look at an example. Here we have the pelvic plane, we have a swing leg, and we have an intact side. See how the pelvic plane is fairly horizontal and the swing leg can clear through during gait. In a damaged individual, see how the pelvis drops on the injured side, therefore making the swing leg longer in essence and having more difficulty clearing the ground as it swings through. To avoid tripping, they either throw their shoulders to the injured side or they'll swing their hip out and clear the ground that way. Either way, they end up waddling because of this injury. Here you can see the superior gluteal nerve coming out above piriformis with the inferior gluteal nerve coming out below it, and the relationships of the sciatic nerve in this area. One thing that you want to remember about tests and signs in general is that this is called the Trendelenburg sign. It is not a test, and the Trendelenburg sign is either there or it isn't there, whereas a test is either positive or negative. So you either have a Trendelenburg gait or you don't have a Trendelenburg gait. You do not have a positive or negative because it is not a test. When we move on to the foot drop, you can see here that we've got a common fibular nerve coursing around the lateral aspect of the femoral head, and it can be damaged through compression or, as we said, a car bumper. It's going to result in the inability to dorsiflex the foot. Therefore, to clear the foot as it sags into plantar flexion, a person high steps and picks up their knee much higher than they normally would. And the flat hanging foot needs to be slapped down on the ground to ensure that they don't trip. So it's oftentimes called a slapping gait. The numbness on the lateral and dorsal aspects of the foot is a result of the cutaneous distribution of both of these nerves as they finish their motor supply and become cutaneous. That concludes session 11 of the nerves of the lower limb. Now in the next session we'll move on to the vessels.